spend this day discussing and talking about medical thoracoscopy or pleuroscopy. It's up to you. The definition is not so important. The main point is to the physician or the surgeon to is at the beginning of the telescope. And we try our best today to have a few discussion concerning maybe the first, it's an introduction. I would like just to remind you the microscopic approach of the pleural cavity. Maybe some people are not so familiar with this microscopic approach, the pathophysiology of the pleural effusion, the fluid turnover. After we discuss the basic equipment for thoracoscopy for pulmonologists, and we see also the basic technique for the management of pleural effusion, for the management of spontaneous pneumothorax, for the talpoudrage, for MPMA if you have the time, and we can discuss. I think the important point is to make this meeting very interactive. Don't wait the end of the lecture to ask questions. Please interrupt me if you don't understand something, if you need more detail, etc., etc. I think it's the best way to work together during this workshop. And tomorrow we have hands-on session on dogs. I think there are 4 dogs, and we can review everything we discussed today using animal in practical situation. The first point is to discuss the first approach of the medical thoracoscopy. I mean the microscopic approach. And
yes,
sir.
We can make full screen.
Yes, I do right here.
Okay.
Don't worry. Okay, good. I think it's important before starting this kind of practical management of the pleura to know what's happened microscopically. Of course, everybody in this room knows that pleura consists of 2 membranes. The visceral pleura, which envelop the outer surface of the lung, which is maybe more important in the parietal pleura. Just to remind you that parietal pleura is considered as costal pleura, I mean on the chest wall, mediastinal pleura, on the mediastinum, but also diaphragmatic pleura. Just, it's a semantic problem where I'm going to talk about parietal pleura. It will mean costal pleura, diaphragmatic pleura, and mediastinal pleura. And we'll see a little bit later how important is the parietal pleura, in particular for pathophysiology, but also for the genesis of a lot of pleural disease. You know that pleural space is a potential space between parietal and visceral pleura, and this space contains tiny amount of pleural fluid, around 0.3 milliliters per kilogram. I think this figure is the most important of my talk. I just want to stress a few details concerning this figure. As you can see here, you have visceral pleura and parietal pleura, and for sure in between the pleural space. We have fat pads under the parietal pleura, and a very important point is the presence of endothoracic fascia. And I talk a little bit later how important is this endothoracic fascia. And after you have the chest wall with the rib, innermost intercostal sphated vessel. Everybody is familiar with this vessel on the intercostal space, and intercostal muscle. Why this endothoracic fascia is so important? Because as you can see here, in modern surgical approach of the pleura, all surgical procedures are made extraplurally. And the surgeon talk about extrapleural pneumonectomy, extrapleural lobectomy. it means that the surgeon is going to make a resection at this level. I mean beyond the endothoracic fascia. And consequently, when you perform thoracoscopy, medical one, and for instance, if you use talc to create a symphysis in patients, of course, with dedicated talc particle, the talc particle still remain at this level. And whatever happen in the future, extrapleural lobectomy, extrapleural pneumonectomy is feasible. And the argument from our colleague surgeon to say that, for instance, in a young patient presenting a recurrent spontaneous pneumothorax, when you decide to create a prosymphysis, is a young patient. Usually the surgeon told you, but Philippe, in 20 years, if this young guy develop lung cancer, and if I have to perform lobectomy or pneumonectomy, it will be impossible due to your talc poudrage at the present day. It's not a valuable argument, you know, because a good surgeon, a modern surgeon, is going to cut at this level. And in any way, there is no problem concerning a talc poudrage with inflammation created at this level and the future potential resection, lung resection. Then you can rule out this surgical argument, which is very important. You have to know that there is 3 types of mesothelial cells, the so-called type 1, which is a mesothelial cell at rest, but also type 2 and type 3, the so-called active mesothelial cells, type 2, and degenerated mesothelial cells. And there is a turnover between these 3 kinds of cells, you know, at rest, active after, for instance, inflammation, and degenerated cells. It's natural, physiological degenerated cell, and there is a kind of turnover around 7-14 days. There is a turnover of this cell. The other important detail is the connection between 2 mesothelial cells. Everybody knows that the cells are connected by a very important part, which is called desmosoma. But for mesothelial cells, there is also a special area called zonular adherens, which make a close connection between 2 cells. And this part is very important for the exchange of the fluid, small particle, etc. We come back to this point a little bit later. What about the function of the pleural space? Our professor, our mentor, told us that it's a very important part because it allows extensive movement of the lung against the chest wall. As you know, maybe it could be questionable. For sure, maybe it's a coupling system between lungs and chest wall, which outward elastic recurrence of chest wall, inward elastic recurrence of lungs, inducing a negative pleural pressure, as everybody knows, around 4 centimeters of water, negative or positive pressure, depending of the respiration. What about the pleural fluid filtration? I mean filtration. By filtration, I mean production of fluid. And what about the pleural fluid drainage? We know now in 2010 that there is 2 ways from pleural fluid drainage: a transmesothelial way through the zonular adherent, through the mesothelial cells, but there is also the most important way, which is the lymphatic way, and I will point out this detail later. When we discuss about pleural cavity and this coupling system, of course we have to discuss about elephant. Why about elephant? Because as you can see here, there is elephant breathing through their trunk while swimming across a river. And you have to know that elephant doesn't have any pleural cavity. And elephant are breathing, you know, it's not a problem for them. The pleural cavity is replaced by a layer of dense connective tissue as you can see here, it is parietal pleura here, it's visceral pleura here, it's a potential pleural cavity, which is plenty of dense connective tissue, as you can see here. The explanation of that is that you have here a terrestrial mammals, for instance. You have atmospheric pressure, 0 in this case, tracheal, bronchus, lung, abdomen, and the rest of the body. You have in the pleural cavity between parietal and visceral pleura, you have a negative pleural pressure. And when an elephant, for instance, is walking on the river, snorkeling, a snorkeling elephant, if he is at 2 meters above, under the surface of the river, for instance, you have to know that at 2 meters there is a pressure of 150 centimeters of water. And then if there is pleural cavity here, you can easily understand that in comparison to the 0 pressure in the lung, you will be an hyperpressure at this level and a compression of all the vessels on the surface of the lung, and consequently you get a pulmonary edema. It's the reason why elephant doesn't have any pleural space filled by dense connective tissue as a tutor, at this level, in order to avoid a huge compression of the vessel on the surfaces of the lung. Then this complex system allowing us to breathe, maybe it's questionable, and we don't know how the pleural cavity is useful, maybe for thoracoscopy course or for workshop, but in reality we do not know why it's so important. If we want to talk about the pleural fluid turnover, which is very important, of course everybody in this room knows the Starling's law. The problem is that maybe this law is not available for the pleural cavity. Just to remind you that this law is a fluid and solute exchange through a semi-permeable membrane, depends on the balance between hydrostatic and oncotic pressures, and you have a very nice formula with the water flux between 2 compartments, the filtration coefficient, the difference in terms of hydrostatic pressure between 2 compartments, oncotic pressure, a difference between 2 compartments, and a solute reflection coefficient protein. But the problem is that the water crosses biological membranes more easily than large solids, for instance plasma protein, and consequently Starling law is not so available, in particular at the level of the parietal pleura. Then there is a second theory, assuming that the production, the filtration, came from the parietal pleura, and conversely the absorption was at the level of the visceral pleura, and you see in this very simple figure how can it work. But the problem also is that this model poses 2 major problems. The first problem is that if you take into account this theory, this second theory, you have a progressive increase in pleural fluid protein concentration due to the different permeability to water and solute. It's the first point. The second point is coming from the difficult absorption of pleural fluid at the visceral level. You have to know that the visceral pleura is thicker than the parietal pleura, between 20 to 100 folds thicker than the parietal pleura. You have to know also that it depends on the animals. For instance, for small animals, mouse, rats, rabbit, and cats, the thickness of the parietal and visceral pleura is the same. But for the big animal, goats, sheep, dog, and human for sure, there is difference in terms of thickness between visceral and parietal pleura, and it's impossible to absorption due to the thickness of the visceral pleura at this level. The absorption is quasi nothing. Okay, it's less than 10% of the pleural fluid. And also you have to know that the visceral level is supplied by the systemic bloodstream, and then consequently the absorption it's impossible at the level. Then it means that there is another way for the absorption, and I would like to discuss the important role of the lymphatics as major routes of plural food drainage. And then the new concept concerning the plural food turnover is for the filtration, I mean the production, mainly from parietal pleura, mainly due to the Starling's law, but which is very important at the present time is a way of absorption, which is the lymphatic drainage through the Wang stoma, which are the special stoma connecting pleural cavity and submesothelial lymphatic vessel. And it's important for us, pulmonologists doing thoracoscopy, that this Wang stoma connecting the pleural cavity and submesothelial lymphatic vessel are located on the special parts of the pleural cavity, I mean at the level of intercostal space, the lower part of the thorax, on the third posterior part of the intercostal space, on the diaphragm, but also on the third inferior part of the mediastinal pleura. And it's important for us, and I show you why with picture a little bit later. And then the new concept of anatomy of the pleural space is, as you can see here, the pleural space here with stoma connecting the pleural cavity and the submesothelial lymphatic vessel. You can see here the parietal pleura, and conversely, at the level of the visceral pleura, which is thicker than the parietal pleura, you can note that there is no connection between the pulmonary lymphatic and the pleural space, and there is no connection at this layer due to the thickness of the visceral pleura, due to the presence also of a strong elastic layer. And then if I want to summarize what's happened, for instance, in case of hyperpressure at the level of the systemic capillary, you can have the fluid going from the systemic capillary to the parietal interstitium, and there is two ways after, through the parietal pleura due to the Starling law and reabsorption at the level of one stoma because of the thickness of the visceral pleura. There is nothing happen at this level, less than 10% of absorption. Or the other way could be from the parietal interstitium through the intrapleural lymphatic vessel at the time and after the lymphatic stream and the main channel, lymphatic channel. Conversely, on the lung side, in case for instance of pulmonary edema, you have a production of fluid from the pulmonary capillary through the layer, vascular layer, through the lung interstitium, as there is no passage through the visceral pleura and a single reabsorption at this level. Of course, in a few situations, you can get a rupture of this visceral pleura, and you can get, in particular, in case of pulmonary edema for cardiac failure. The mechanism is not so simple to understand, but you have to know that in this case there is a hypoxemia at the peripheral part of the lung. There is production of cytokines, in particular IL-8, TNF-alpha, and there is a rupture of the mesothelial layer, and consequently fluid can come from the lung interstitium to the pleural cavity at that time. But usually in the most simple situation, this way it's the main way. And then from my friend Miserocchi from Italy, you can summarize what I just was telling you. The drainage is from less dependent area to the most dependent area of the pleural cavity through the Wang stoma, mainly, as you can note here, located on the diaphragm, located on the posterior inferior part of the pleural cavity, on the hilar area and the mediastinal area. And of course, in standing position, it's from the apex to the diaphragm, in supine position, anterior to posterior, and costal area to the hilum. And you have here the main intrapleural fluid drainage and the lymphatic drainage, with summarized by these arrows. You have to know also that parietal pleura and visceral pleura are lubricated because there is two tangential actions due to the presence of double layer surfactant at the level of parietal pleura but also visceral pleura, and it means that there are a kind of polarized dipole at this level lubricating the pleura and inducing a very low friction coefficient similar to hydrodynamic lubrication, for instance. And what happened in elephant, because there is no pleura cavity, the tissue are very plastic, and then it is the reason then the respiration, inspiration, expiration is possible for this animal. Otherwise, there is this presence of polarized dipole. To finalize the pleura food turnover, what is the main point concerning the absorption? If you look at this figure here, you have lymphatic conduction. I mean the possibility to absorption. For absorption, it's pleural liquid volume here, and you have the filtration coefficient here. I mean the production of food. And as you can see here, even in case of huge amount of fluid, maybe for instance 10 liters of fluid, due to the lymphatic conduction you get only a pleura food volume less than 2 liters. It means that in this case you have a huge absorption of the pleura cavity, and if you multiply by 10 the filtration coefficient, you only multiply less than by 2 the pleura food volume. And then it means that if you take into account the point A as a value of the pleura food control expect to equal 1, the area ABC, it's an external lymphatic control. The B, it's a lymphatic system filtration. It's the maximum capacity of filtration. And of course, when you have a filtration superior to absorption, you get a pleurisy according at that time the Stirling law. In practical, what happened? You have here a parietal pleura from a rabbit. It's the same in human. And as you can see here, Van stoma, it's something real in the real life. It's materialized by this point. As you can see, if we take a closer look, you can see here where you are in the pleura cavity here, and you can go into to reach the submesothelial lymphatic channel. As you can see here, there is a pleura cavity here. You have a lymphatic vessel here. You have Van stoma here. You have mesothelial cell here. You have endothelial cell here. As you can see here, we have a connection between pleura cavity and lymphatic vessel. These Van stomata are located on the special part, as I already told you, in the pleura cavity, but they are surrounded also by very important cells, I mean lymphocytes, I mean macrophages. As you can see here, it's a parietal pleura from asbestos exposed patient. It's a study we did with my mentor, Professor Boutin, a long time ago, and we took patients with pleural effusion, asbestos exposed patients, and we analyzed a special area of the parietal pleura and the posterior inferior part of the parietal pleura, and macroscopically we found Van stoma, as you can see here, but we found also very important cell, as you can see, macrophages, lymphocyte. And this from a publication from Wang, Nathan Wang, who died 5 years ago. It was a guy from Canada. As you can see here, it is a red cell from the pleura cavity engulfing by the Van stomata and also by the lymphatic channel. And the pleura food turnover is, pleura food production is around 15 milliliters per day, and for sure the pleura food absorption is the same. It's the reason why there is no pleura effusion, 15 milliliters per day. And pleura food then, to summarize, drainage is achieved by the lymphatic pump. It's a lymphatic pump because it consists of rhythmic contractions of small muscle of lymphatic walls. and also a tissue pressure oscillation related to respiratory movements, which is very important. It's kind of, there is valve at the beginning of the lymphatic vessels which allow the fluid, the lymphatic fluid to progress inside, generating a pressure around 10 centimeters of water, negative pressure. And the maximum fluid drainage capacity is around 300 milliliters per day. Then the new concept for pathogenesis of pleural effusion is, for sure, pleural effusion develop only when increased production of pleural fluid exceed maximum drainage capacity, but you saw that it was adaptable way. What's happened, for instance, when there is increased pleural fluid production? Which situation, pathological situation we have? We can have increased interstitial fluid in the lung, as we can see in case of left heart failure. We can have increased hydrostatic pressure gradient in pleura by increased intravascular pressure, as we see in case of superior vena cava syndrome, or due to a decreased pleural pressure, for instance, during an atelectasis. We can get an increased capillary permeability due to the modification of the coefficient filtration, for instance, in case of pleural inflammation, or decrease oncotic pressure gradient, as we are seeing in case of hypoproteinemia. The second possibility can be the decreased pleural fluid drainage capacity when we have obstruction of lymphatics, or in case of elevation of systemic venous pressure. And just I would like to finish my presentation and come back to the practical situation. When you perform thoracoscopy in the near future, you can find non-specific aspects of the parietal pleura, as you can see here. But you have to be very cautious concerning this black deposit, the so-called black spots, as we described with Boutin 15 years ago, because these black spots are a natural marker. It's anthracotic deposits, but it's also a natural marker of stoma in the pleural cavity. And we know from previous studies that at this level, for instance, in case of asbestos exposure, we have plenty of oncogenic asbestos fiber. And if you have a non-specific lymphangitis, as you can see here, and we found this, you have to target your samples at this level, and you can take biopsy at this level. You can see here lung, parietal pleura with intercostal fat. As you can see here, there is very nice pleural plaques in this patient with asbestos exposure. But if you take a closer look, you have here nodule, and it was a very early stage of malignant mesothelioma. In this case, for instance, you can see the black spot here, you can see the lymphatic vessel, hypertrophy, lymphatic vessel, we can see malignant nodules here, and it's very, very important area. And my take-home message here at the end of my presentation is, if you have non-specific parietal pleura, just if you have black spots at this level, it's very frequent, in particular in smoking patients, but also due to the pollution, etc. Take biopsy at this level. It can target your procedure, your biopsy. Okay. Do you have any question concerning this first approach of the pleural cavity? Maybe new approach for you? I don't know. Gentlemen, ladies. Yes, sir. Please. Maybe you can take ambulatory microphone. You have your microphone. You propose me. You suggest me a microphone, maybe in the room. Should be better.
It's okay. Okay. I think, sir, that you said, or you denied, as on your presentation the role of visceral pleura in pleural fluid drainage.
The role of, of visceral pleura, it's very low.
Yes.
It's less than 10%.
Yes. Some papers say it's minor rule or no rule, but I agree that it has a minor rule, but no rule. I think it's very difficult.
No, there is no rule. It's impossible in this case. Yes. In particular, when you have a large amount of fluid, okay, you can get a passage at this level through and between. And between the mesothelial cell on the visceral side. Why? It's not through the mesothelial cells. Sometimes in this situation you have a kind of hypoxemia of the peripheral part of the lung. It means, and then a kind of relargage of secretion of cytokines in particular, which play a very important role in the inflammation. For instance, TNF-alpha or IL-8, etc. And then you have sometimes a leakage at this level of visceral pleura between a mesothelial cell, and it can be an absorption due to the difference in terms of pressure, okay? But it's less than 10%.
The normal pleura, even not the pathological pleura, I think it has a minor rule, not absolutely no rule. For
in physiological condition, there is no exchange at this level. In physiological condition, nothing happens at the level of visceral pleura.
Nothing, zero.
Nothing, zero. In physiological condition. It's there are very nice study carried out by Chinese team and Japanese team, but also the team from Italy, Miserocchi and Monza, and Manuela Negrini, who is doing a very nice job in this field, showing that microscopically nothing, in physiological condition. Everything happened at the level of parietal. You know, if I want to summarize what is pleura, for everybody, pleura, it's a bag. No, it's wrong. It's not a bag. It's a real organ. Maybe visceral pleura is a bag. It's a stupid bag. But parietal pleura, it's a real organ. A lot of things happen at this level. Filtration, absorption, the genesis of oncologic situation, etc., etc. Even for infectious disease, etc., etc. We can discuss this point a little bit later. Any other question, comments, please? Try to make this morning and afternoon very interactive. Yes, sir. Please.
The information that the visceral pleura is thicker than parietal pleura.
Yeah, yes. 2200 times thicker. 200 times. It's huge in comparison to the parietal pleura in big animals. It's a reason why to correlate experiment study on mouse, rats, to the human, there is drawback due to the difference in terms of thickness of the pleura, you know. But in big animal, as I can show you, for instance, in the talpurage study we did on goats, for example, where for goats the visceral pleura, it's as a human thicker than parietal pleura. But for the small animal, it's the same. But in a big animal, it's very different. It's much more thicker. It's the reason why the absorption capacity are quasi nothing.
Second information about the level of surgical interference. If there is
The level of
surgical interference, if pleurodesis was done to a patient before, it does not prevent the process of lobectomy or
absolutely. Even no preclude transplantation. If you look at the very nice study carried out by my friend Stephen San from Charleston in United States, Stephen is the head of the register for lymphangioliomyomatosis. And if you look at the very nice paper he published in 2006 in European Respiratory Journal, it's more than 110 patients undergoing transplantation after talpoudrage. The conclusion, it's American people, you know, and it was very difficult to make American admitting talc, but it's coming. And in this paper is shown, very nicely shown, that after transplantation for this patient, there is no more morbidity, no more mortality, operating morbidity and mortality, and no more blood transfusion. 110 patients, which is not too bad. I don't say that it's easier to perform transplantation after tapoudrage. It's feasible. The problem is the diaphragm. For instance, when you have a patient with recurrent pneumothorax, as we can see in the case of cystic fibrosis, lymphangiomatosis, histiocytosis, etc., and who is on the waiting list for transplantation, we usually don't apply the talc on the diaphragm. We put on the upper part, and sometimes we get recurrent pneumothorax, but partial recurrent pneumothorax, it's not a problem. But another point, you know, 15 years ago, when we applied the multimodal therapy for mesothelioma, for instance, you know, including extrapleural pneumonectomy for suspicion, our colleague surgeon in Marseille told me, Philippe, please don't apply talc because it will be difficult for us to perform extrapleural pneumonectomy. And now, he told me, please, can you apply talpoudrage, because using beyond the endothoracic fascia, I can make my procedure unblock. As you peel an orange, you know, because of the talc, there is symphasis inside, but outside, beyond the endothoracic fascia, it makes the procedure easier for them. You know, definitely. Talc is not a problem for a modern surgeon. I mean, all the procedure performed extrapleurally. It's not a pleural. It's beyond the endothoracic fascia. Okay? It's an important question. Yes, madam?
I want to ask about the surfactant which lies the parietal and visceral pleura. It is secreted from which cells? As we know, it is secreted from type 2 alveolar cell in the alveoli to prevent its collapse.
I'm sorry, I didn't catch your question.
About surfactant.
Yeah.
Surfactant, which lies the...
What do you mean, surfactant?
Surfactant
of the mesothelium, of the pleura.
Of the pleura. Mm. It is present from, it is secreted from where? What cells secretes the surfactant? It is secreted from the alveolar cell type 2 in the alveoli. It's
on the surface of the mesothelial cells.
Yes.
It's on the surface of the mesothelial cells.
What's its function?
It's going to be, I can show again. It's just to make the, just to make to lubricate, to make easy the movement, you know, the movement on the lung, on the against the chest, make it easy. It's like a lubrification.
It is secreted from what cells?
Mesothelial cells, monolayer. Okay, it's like this. You have, for instance, visceral pleura here. It's mesothelial cells, and you have on the surface of these cells the molecule. It's a polarized dipole, as you can see here. It's kind of stuff like this in order to make all the two layers moving very easily.
Is it different chemically from the surfactant that we use?
Absolutely, totally different. It's not the same surfactant than the alveolar. It's your question? Okay, it's different. Okay. But you have here, it's usually it's palmitic chains and hydrogen bridge in between, which is different from the surfactant from alveolar. Okay.
But the function is the same.
No, surfactant in alveolar is to make an easy inflation of the alveol. In this case, it's to make a lubrification, which is a little different. Okay.
Not from lymphatics.
Excuse me.
It is not a lymph fluid.
No. Any other comment? Okay. Yes, sir.
It's regarding the elephant thing. Yeah, you mentioned that they don't have a tourist or they don't have food in the tourist they have some kind
Never food.
So doesn't it make the breathing is difficult on the walking grounds and so?
No.
And
It's
so
the reason why we don't know what's happened in pleural, but we have the same in human. After tapoudrage in young guy, we know that 1 year later, pulmonary function tests are normal. So we know not restrictive syndrome. And this guy, pleural cavity of this guy becomes elephant pleural cavity, you know, with symphysis. But everybody can breathe. Maybe pleural cavity only for the thoracoscopy course, dedicated.
it means that they don't get any pleural effusion.
Absolutely, never. Well, we can discuss this point, animal. It's very interesting. The anatomical comparison between animals is very interesting. And in the next year, we discuss about buffalo pleural cavity, which is very interesting too, because there is a single pleural cavity. It's the reason why Indian people can kill with arrow a buffalo, because there is single pleural cavity, and consequently there is a bilateral pneumothorax, and he died. But it's another story.
Can I ask what the pleurodesis for will come?
Excuse me?
Can I ask about the pleurodesis now, or it will come later?
Oh, we come later, because it's a very controversial issue, very discussing issue. But no, it's not, still don't remain controversial, but we have discussed this point.
Okay.
Okay. Then you'll start thoracoscopy very soon, I hope. What you have to know, what about basic approach of medical thoracoscopy, pleuroscopy. The definition is not so important for me, but we can discuss this point. The first point is anesthesia. It's simple. It depends of your facility. You can perform thoracoscopy under local anesthesia, I mean local loci or single lidocaine on the skin, neuroleptic analgesia, intubated patient, tracheal intubation, or under general anesthesia with or without intubation too, Rheingold mask, whatever you want. It's not a big deal. It depends on your facility, it depends on your colleagues, it depends on your colleagues anesthesiologists, etc. I think the first take-home message is try to keep the patient in spontaneous breathing. It's very, very important. Because in ventilated patient, you will be boring by the re-expansion of the lung. And then it's much more easier to perform thoracoscopy in patient with spontaneous respiration. Okay? It's the first point message. You see tomorrow with, I think we work with dog tomorrow. It's more difficult to perform thoracoscopy in animal for sure. But if you know to perform thoracoscopy in dog or in goat or in sheep, etc., it's much, much, much more easier to perform thoracoscopy in patient. Patient is the best animal we have. Okay? In Marseille, we start by patient after we go to the animals, just in case. The patient position is lateral decubitus, as you can see here. It's our former facility. We have a new facility since the last week. Very nice facility. And as you can see here, I put 2 points of entry. It's not 99% of the procedure are performed with single point of entry, just to show you for pleural effusion. Usually we shows, it's important message, fourth, fifth, sixth intercostal space on the middle axillary line. It's for the pleural effusion, and for pneumothorax it's a little bit higher. It's third on fourth intercostal space same middle axillary line. Okay? It's just a simple message, but you know, thoracoscopy, it's made by few details, making the procedure very safe and easy. The first step of the medical thoracoscopy is to create, of course, an artificial pneumothorax. You have to go into the pleural cavity, and the first step is to perform pneumothorax. There is different option to perform pneumothorax. In Marseille, the patient is in spontaneous breathing, and it's easy for us to perform a thoracentesis on the table if the patient has fluid, and to make the air enter into the needle. It's an active artificial pneumothorax, and it's easy to remove the fluid and to replace the fluid by the air spontaneously, of course, due to the negative pressure into the pleural cavity. In patients with a few amount of fluid or no fluid, in case of single pleural tumor, we create the artificial pneumothorax the day before the procedure in order to see if there is no adhesion, and in order to show us after chest X-ray, oblique chest X-ray profile, etc., in order to show the proper point of entry at that time. But if you have CT scan, of course, you can rule out this. But it's always safer to see if you can create artificial pneumothorax before the anesthesia or before to arrange everything in the operating room or endoscopic room. We use this pleural needle. It's a needle with 3 parts, the needle per se, and the first mandrine with a blunt tip pointed tip to go through the skin. You replace this mandrine by the other one with a blunt tip in order to avoid the wound of the lung. And after you remove the mandrine, you open the tap, and then the air going to. It's easy to do, and you do with animal tomorrow very easily, but you have to know that the pleura is very thin because your animal tomorrow will be healthy, I hope. Sometimes dogs are large emphysema bulla. It's always, there is a lot of dogs with emphysema. And but the pleura is thin, and if you can perform artificial pneumothorax in dogs with healthy pleura, for sure, in patients with 2 liters of fluid or 1 liter of fluid in the pleural cavity, it's easier to replace the fluid by the air. It's not a big deal. The first step is to create the artificial pneumothorax. As you can see here, you put the needle inside, we replace the mandrine with a pointed tip by the blunt one to go through the pleura, and then we open and the air coming too. You can check the intrapleural pressure with a simple device. You connect with you connect the needle with this catheter, and you have at the end a kind of centimeter to see the pressure. We can discuss this point if you want. Second step is make a gentle incision, and you dissect the chest wall, never cutting inside, only a dissection of the muscle, etc. And after you insert the pleural trocar. In Marseille we use this kind of trocar. It's a 7 millimeter trocar. We have also a 5 millimeter trocar, which is insulated to use coagulating forceps just in case. We discuss also the indication of second point of entry and the indication of the use of the coagulating forceps. And as you can see here, the trocar is in place, and you can start your procedure using such telescope. It's a 7 millimeter telescope, as you can see here, with 0 degree angle, and 7 millimeter telescope with oblique angle around 45 degree. My opinion is that it's the most important tool. It's optical biopsy forceps. Of course, with this forceps you cannot apply coagulation. to apply coagulation, you have to use this coagulating forceps. You use 5 millimeter trocar, insulated trocar, and you can work with 2N, as you can see here. And the basic requirement, I think, for the thoracoscopy is to get this 7 millimeter telescope for a good analysis, to get this optical biopsy forceps, because 99% of our procedure are done with this single material, and just you absolutely have to get this optical biopsy. But just in case you need coagulation, it's easy under visual control to create a second point of entry, as you can see here, under visual control from outside or from inside, you can see. And then at this level, you can put the 5 millimeter telescope, 5 millimeter trocar, and I show you. And then you can go through and then put your coagulating forceps in this trocar. The main indication of second point of entry and the use of coagulating forceps is biopsy of a vascularized area of a parietal pleura, but usually we do not need this forceps to perform biopsy. In case of bleeding, it's the reason why you have to get coagulating forceps. For thoracoscopic debridement, in case of adhesion, or to coagulate air leak, or to perform pulmonary biopsy, which is easy to perform during a thoracoscopic procedure. The last step of your procedure, after careful examination of the pleural cavity, after sampling the pleura, is of course to re-expand the lung. As you can see, for who never seen expansion of lung from inside, it is, you see the expansion of the lung in this patient with malignant nodules here, and underwent talpoudrage, as you can see here. In Marseille, we used to perform thoracoscopy in quasi-ambulatory design. We remove the chest tube on the table, as you can see here, in case of diagnostic thoracoscopy. Of course, when you connect the tube to a bottle, you apply gentle aspiration, under 50 centimeters of water, negative pressure, and when the bubbling stops in the bottle, you remove the chest tube, just as you saw on the screen. Of course, in case of therapeutic thoracoscopy, mainly after talpoudrage, you keep the chest tube in the pleural cavity till you remove 150 milliliters of fluid each day, and then you can remove the chest tube with the same attitude. The main contraindication, not contraindication, but the main problem you can get in case of indication of malignant talpoudrage, it's a so-called trap lung, as you can see here. For whom who never seen a trap lung from inside, you see the lung, there is a fibrotic lung, and of course this kind of lung cannot re-expand. It's not a big deal, because the people are afraid by air in the pleural cavity, but it's better to get 2 liters of air in the pleural cavity than 2 liters of fluid. I can tell you, it's less symptomatic, and that it's not a big deal. Sometimes, even in case of trap lung, we go through thoracoscopy to make a diagnosis. We try a symphysis, but the main point is to advise the patient that maybe we get prolonged drainage and also a failure of the symphysis. Then to summarize the drainage duration, in case of diagnostic thoracoscopy, usually it's less than 1 hour for us. We remove the chest tube on the table or in the recovery room in patient under general anesthesia. The messages for our nurse, it's very important. It is not more work, not management of the chest tube in the ward, which is very good, because it takes time, it's time consuming to take care of chest tube aspiration, etc. And in case of diagnostic thoracoscopy, you do not need a prolonged drainage of the pleural cavity. In case of diagnostic thoracoscopy after pulmonary biopsy, we have our series is around 2.5 days. My opinion is, but we didn't perform a clinical trial. I think you can very easily check if there is air leak, and we do tomorrow with animal. We can remove the chest tube the single day, the same day also, but we didn't perform such study, and I don't want to advise you to do the same. In case of talpoudouage, for recurrent spontaneous pneumothorax, it's around 3.5 days. For recurrent magnum-pleural effusion, it's around 4 to 5 days. The problem is transudative effusion, but the indications are very rare in 2010 due to the improvement of the management of cirrhosis for our colleagues, gastroenterologists, and in particular the TIP system. And we have very few indications, but it's available to try pleural symphysis for such patients with transudative effusion. In our series, we have around 50% success in this case. What about thoracoscopy morbidity? You can get fever in particular, and you have to know this after talpoudouage for sure, due to the cytokine cascade induced by the talc in this situation. And of course, it's not infectious disease at that time, and it's not useful to apply antibiotic, etc. Subcutaneous emphysema is very rare. Skin infection also, it's very rare. Asymptomatic pneumothorax can happen, in particular when you remove the chest tube on the table, but usually it's very teeny pneumothorax, and which solve spontaneously the same day or the day after the procedure. And you can get paresthesia and pain on the port of entry side, but I have to say that since we remove the chest tube on the table, there is no more problem at that time. And if you avoid to cut during your dissection the chest wall, I mean to cut the muscular fiber, etc., dissecting like this, always opening your scissor, etc., you avoid this kind of secondary effect, which are the problem for the patient, because it can be painful a long time, and then it's not so good. If you look at the literature, just to briefly summarize, the mortality of thoracoscopy is around 0.24%, is less than mortality after transbronchial biopsy during bronchoscopy. And you are pulmonologists, maybe everybody in this room perform TBB, transbronchial lung biopsy. You have to say that thoracoscopy is safer than this procedure. And you are not reluctant to perform TBB. Don't be reluctant to perform thoracoscopy, which is much more safer. What about the patient preparation for such procedure? Usually in Marseille we use, but we have privilege in Marseille because we have a thoracoscopy room, dedicated room. We have endoscopy suite with a bronchoscopy room for bronchoscopy, interventional bronchoscopy, and just close to this room we have a thoracoscopy room. We have 2 anesthesiologists dedicated for bronchoscopy, interventional pulmonology. Of course, it's a privilege, but we try our best to make this procedure easier. But we used to perform this procedure under cardiac monitoring. We try to be very cautious in patients with PaO2 inferior, of course, 50 millimeter or PaO2. Coagulation have to be correct, in particular taking into account the platelet counts. We try to postpone the procedure in case of febrile patients. Of course, if the indication of the thoracoscopy procedure is MPM, of course, we perform the procedure, and we try to perform the artificial pneumothorax in the theater when there is pleural effusion, and we think that the pleural cavity is free of adhesion, free pleural cavity. But if we have a suspicion of loculated pleural effusion or something like that, you can try to perform the artificial pneumothorax the day before the procedure. My young colleagues, because I'm an old profession, but my young colleagues use ultrasonography to check the pleural cavity, which is very relevant, of course, but as I told them, it has costs for the procedure. And I think 98% of the procedure don't need ultrasonography assessment of the pleura, but it's okay, you can check the pleura using ultrasound. And we postpone the procedure in patient with cough because it's always boring to perform this kind of procedure in such patient, and I was already talking about the fever. What about the indication of this procedure? Of course, the main indication is diagnostic thoracoscopy for the management of pleural effusion at the beginning. The aim of the procedure is to sample the parietal pleura and sample the visceral pleura and or the lung. The first step, you see this patient with artificial pneumothorax. The first step, of course, is to remove all the fluid for the pleural cavity. You can tap the fluid, you can analyze the fluid, cytology analysis, immunohistochemical analysis, biochemical analysis, microbiological analysis of the fluid. But you have to remove all the fluid in order to carefully analyze the pleural cavity. And then, as you can see here, after removing all the fluid, you can get a very nice view of the pleural cavity. Maybe you saw yesterday this picture. It's asbestos exposed patient. As you can see here, the lungs, the fissure here, the very nice pleural plaques here. What is important, it's not the pleural plaques, which are benign, of course, but it's a non-specific lymphangitis in between. In this case, I repeat, it was a very early stage disease of malignant mesothelioma. And then sampling this area, but he had also few nodules in this location, located at this area. It was management, and you see this patient had on the CT scan non with recurrent malignant pleural effusion. As you can see here, the three lobes, atelectatic lung, upper part. I just would like, it's a diaphragm. You see the nodules are mainly on the diaphragm, on the gutter. There is a lung, there is pericardiac fat, with invasion of the fat, pericardiac fat, atelectatic lung, inflated lung. You see the parietal pleura, it's free of disease, and for sure, using percutaneous pleural biopsy, you cannot reach this nodule on the diaphragm. And it was very nicely shown by Cantor a long time ago in 1983, showing that it's more than 60% of the patients, the nodules are located on the diaphragm, on the mediastinal pleura. And blind pleural biopsy, you cannot reach this nodule. It's the first step. The second step is, of course, if you wait, as did by our colleagues from United States, you can make the diagnosis at autopsy. For sure. And for sure, if you wait, if the nodule spread all the pleural cavity, your percutaneous pleural biopsy will be fine, but in very late stage disease, too late. You understand? Same for this patient. You see, it was sarcoma actually, and you see the nodules are located on the diaphragm mainly. And then you cannot reach this. The other part and the gutter, you see, and the other part of the parietal pleura, etc., is free of disease. It's impossible to perform. There's huge nodules, but this patient got 8 percutaneous pleural biopsy within 4 months. What does it mean? It's impossible. Fluid, strong suspicion of cancer, mean thoracoscopy. In this patient, we removed the chest tube on the table. He was discharged the same day. In 1 day, you rule out 4 months with 9 percutaneous biopsy, pain for this patient, anxiety, etc., etc. What about, yes, sir? No, you have to interrupt me, please. It's okay.
What about the closed pleural biopsy using the Abraham needle? Is it
Using?
closed pleural biopsy using the Abraham needle?
It is,
It is
you don't have the paperboard here.
the stage before.
You don't have a paperboard.
ما عندكش ورق نرسم عليه
How can I explain you? You know the Abrams,
في بورد كده
the diagnostic yield. Yes, I used to it. I use Abrams needle to teach my fellow because I think that a pulmonologist has to know to perform percutaneous pleural biopsy. My opinion is that in 2010, also you have a strong suspicion of pleural tuberculosis. You perform percutaneous pleural biopsy because the diagnosis is very high in this case. Otherwise, in a modern approach of the pleural disease, there is no place for percutaneous pleural biopsy. Why? Because the diagnostic yield is related to the stage of the disease. If you want to perform an early diagnosis, you have to take a look inside because the diagnosis of your procedure will be very bad. If you perform if you perform percutaneous pleural biopsy with positive diagnosis of cancer, for instance, before doing thoracoscopy, you do not know if you have an invasion of the diaphragm, if you have an invasion of the visceral pleura of the lung. It's a very important prognostic factor, you know. Excuse me? Yeah. Say again? We discuss this point the next topic concerning malignant pleural effusion. It's a very important question you have. Thank you for asking this question. It's very important. I show something. Okay, good. What about the technique of the parietal pleural biopsy using optical biopsy forceps? We apply in Marseille the so-called, we call this peeling biopsy, as you can see here. You have the nodules on the parietal pleura, you rub the forceps, you grasp the nodule, and we peel the parietal pleura. The lung is here, of course. I just would like to show you that it's a very deep biopsy. Look at this part of the screen. You see the rib when we peel the pleura. And the second point is that there is no blind period, you know. You see what's happened beyond the tip. You see the rib? Beyond the tip of your forceps. It's very important. It makes your procedure safe, you see? Because if you apply the technique of punch biopsy, pulling the pleura like this, you do not know what's happened beyond the tip of your forceps. If you grasp a vessel, you peel you take everything and you make bleeding, you know. Like this, you avoid this kind of complication because there is no any blind period. It's deep biopsy. You can elicit what's happened, and you have a huge specimen for sure. In this case, it was easy to take because there is plenty of nodules, but it makes the procedure easier. Yes, madam.
We are fixing the forceps, but we are moving the telescope.
What do you mean? It's optical. In this case, I use optical biopsy forceps.
Yeah. I mean, we are not moving the forceps.
You can move in the forceps like this if you want, and we peel like this.
No, she means the vision. She doesn't understand the optical.
Yes.
You can see
Yeah. It's this forceps actually. it's made by two pieces, the forceps, and you put inside a 4 mm telescope, and then you can see what's happened. Okay? You use this tomorrow. No, I think we have a tool from a Storz company, right?
Yeah.
Okay, there is no optical biopsy force, but there is a working channel to put a forceps inside, because we use a wolf.
We need another port to see something.
No, actually, no. If you have the Vor's Storz device, you can. I don't use, but I know. There is a working channel you can put through.
No, I mean to see. To have
But you have it's a bayonet.
Ah.
And it's like this. You see like this, and you have the channel just under. I think I didn't see your. Again, it's optical biopsy. You do like this under visual control. You understand?
We use the fiber optic fluoroscopy or what?
No, it's
This is
optical
with-
biopsy forceps.
With trocar and telescope, or with one biopsy and we enter the channel through it, like the fiber optic.
No, it's no. I
cannot
the optical
imagine.
No,
biopsy
it's
forceps
not-
is just an instrument, but already you have the trocar inside one trocar,
Yeah.
and you're using this forceps, okay? And you can see, and you're putting it through the trocar and seeing what you're taking. As long
You
as
see.
know the trocar, it has nothing
it is you put this trocar here, okay? You put this trocar here,
Yeah.
and through this trocar you put this forceps, okay? Am I clear? You understand?
So, about the position of the trocar and the telescope, the distance between them first and the direction, is it opposite each other? Or
But
what?
it's under visual control. You have
I know there is two boards.
no, one port in this case.
One port. Look,
One port.
you enter with this telescope up here. It's the rigid one.
You put
Yeah.
you put this.
You're sure.
So where can I put the telescope?
You put this telescope. This.
بص عليه،
Is-
بص على الشاشة.
You put this here inside.
This is the trocar.
Yes.
Where is the telescope?
He showed you before.
Not yet. I show you. The telescope is here. You put the telescope inside.
Inside the trocar.
Yes.
And when I put the forceps,
Yes.
take
It's
the telescope
you
out.
put you put
telescope
this.
out.
You put this. You
So
put.
how can I take the biopsy under vision if I remove the telescope out and enter?
Because this is vision.
No. It's a vision here.
Yeah.
عدسة.
There is a telescope inside. It's optical biopsy forceps.
Yeah.
I mean, there is a two-piece.
The problem
There is
that
a forceps here, and this is this.
Yeah.
This is this telescope you put inside, and total you put in the second point of entry here. You understand?
The problem that our thoracoscopy in our hospital is absolutely different.
You
There is
don't
one port-
have an optical forceps. You
Yeah.
can't see.
We have.
You only have a rigid
optical.
telescope, which you can see with, but when you have to have a biopsy, it's without a lens. So you
Yeah.
have to have another port
Yeah.
and see what you're taking.
That's the problem.
That's the. That's
Yes,
yeah.
but
So I'm asking about the second port for the telescope. Where can I put it?
She's not talking
The
about this
distance
case.
between
She's
the
not talking
trocar
about this case. She's talking about if she had a rigid scope.
okay.
without,
You mean that you have a single point of entry for the telescope,
Yeah.
and you have to perform second point of entry to put the forceps, right?
That's
Like
right.
this,
yeah,
like this,
like this one.
for
like
instance.
this.
But here I take the lung, but you can take also the parietal pleura in the same way.
She's
What,
asking about the distance between, in this case, the two ports. What's the distance
And also
between?
the direction.
okay.
Can I
It's,
put one opposite the other or in the same direction? Or what?
it's a good question.
And according to the size of the lesion also, where can I put the telescope?
Yes.
The import telescope and trocar, and the trocar.
Okay, I understand now. Okay, when you use a second point of entry, the position of the physician is important, because our colleagues, surgeon,
Why do you want this? You want this?
are
beside
on
you?
the back. Yes, put here. Okay, our colleague surgeon are on the back of the patient.
Yeah.
We are facing the patient. I mean, we are facing the patient because when you enter into the pleural cavity using the middle axillary line, you are in front of the posterior parietal pleura where there are vangstoma, etc. You know?
Yeah, but
And for the
Cinematic.
and for the second point of entry,
Yeah.
you use the same axillary line, one or two intercostal space above or below.
Yeah.
Am I clear?
Yeah.
Good.
So the both directions is towards the parietal.
You have to work like this. I show you tomorrow. You have to work like this.
Yeah. So I have to be in front of the patient, not on the back.
Absolutely.
This is the
You know
first-
why? Because if you are on the back, you enter into the pleural cavity, you are in front of the anterior parietal pleura, and in this area you have internal mammary vessel, etc.
Yeah.
First. And second, there is no stoma. There is no lymphatic at this level. They are on the back. And then you have to look like this.
Yeah.
It's the reason why we are facing the patient. We are in front of the patient in order to be, when you enter into the pleural cavity, on the back, in front of the posterior parietal pleura. You understand?
Yeah, I understand.
Okay.
And on the mid-axillary line, it will be the incision of both the trochal and telescope in the same level. The same level, not in the
You have the patient like this. It's the patient like this. And then you have the middle axillary line here, for instance, okay? You are at the level of the fifth intercostal space for your telescope.
Yeah.
Okay? You want to circle because here is the posterior parietal pleura. You have stoma at this level, inferior part. You have the diseases of all the process, oncologic process, etc. And then the aim is to be very safe and relaxed, just in front of the posterior parietal pleura. And then if you need, as you need, the second point of entry, you show the same axillary line, one or two intercostal space above or under. Okay? And you work like this. And if you work like this, okay? And I show you tomorrow, there is 2 points. If you want to see very easily the tip of your forceps, you keep your telescope like this, examining the posterior parietal pleura, and parallelly put your forceps like this till the posterior pleura. Then you can see the tip of your forceps. The second is to keep your forceps like this, and inside you do like this, and you do like this, and then the tip of your forceps happy. Okay? But the aim of the procedure is to work like this, using 2 hands.
Perhaps a good question is, Dr. Philippe, if the lesion is extensive and all over the parietal pleura. But what if, like sometimes we see, it's localized in the costophrenic space or something like this? Then do we change the direction in this case?
Actually, it's the reason why we, in such, when you are very few lesions, in particular pleural tumor without fluid, we create a water as I did before in order to show the proper point of entry, in order to make a careful analysis of the lesion, and in order to show the second point of entry. But the first step is to make a good exploration of the pleural cavity. And if you have a single lesion in the pleural cavity, I mean, I don't know, on the apex or on the costodermic gutter or anterior, you show your point of entry in order to be very comfortable. Of course, if I make my procedure like this and my patient here, I'm facing the patient, I have a lesion here, okay? And I make my exploration, 60 degree, and I see a lesion here, okay? I'm going to show the point of entry here, and I'm back to the patient just to see what's happening.
Yeah.
It's located correlation, you know. You show the second point of entry, but in more than 95% of the cases, you have a lesion on the posterior parietal pleura.
Yeah.
Don't worry for that. For you, for example, you don't have a single optical biopsy forceps, whatever the style that this Wolf company or sport, you see the bayonet instrument I mean. And then I think, so last year when we use this, maybe it's the same, I don't know.
I'm not sure. No, I'm not sure.
I know that the sports company has this kind of telescope. So you have to put the 8
Much easier. Much easier.
Or we can use the work from both company. I have no interest in medical technique. It's not a problem for me. You can do whatever you want. For sure, if you need second point of entry, 99% of the procedure will be like this because the lesion will be here.
Yeah.
Okay? But if you have a lesion here, of course, you do the same thing, but you make around. You will be here in order to sample here. You understand? If you have, for instance, I don't know, a lesion here and it happens, you try your best to have your forceps here in order to see what's happening, etc., etc. But it's insufficient number of cases. Okay? Yeah, good question. Thank you for the question. It's important to see the detail. Okay? Second.
You said that we can see the ribs, but I cannot detect the ribs here. I usually used to peel the rib before I
Yes, yes,
grasp.
but it's but you see, I grasp, and you peel. You see here the rib. Here,
هي البيضة دي.
it is a rib. You see?
No.
Sorry.
Come close.
Here you have the rib when I peel. Look at this. This white bundle is a rib. You see it? You can believe me, it's a rib. I can tell you. Actually, usually in case of advanced disease, as this case, the pleura is very thick. You know, it's difficult. But when you have few nodules in the pleural cavity, it's an important question also, the location of your biopsy. If you have the choice, try to sample on the rib because you avoid the intercostal vessel. Okay? Of course, if you have a nodule in intercostal space, you grasp very carefully. Using the peeling biopsy, you can see what's happened beyond the tip of your forceps. And then if there is a vessel, you stop. You understand? Just under visual control. Okay? Second main indication of the procedure, here's spontaneous pneumothorax. I think it's a real medical indication of thoracoscopy. And as you can see here, for instance, this young patient, smoking patient, as you can see here, anthracotic deposit, it's a parietal pleura, it's the apex, it is a blebs, it's subclavian artery here. We have a very nice view of the subclavian artery here, apex, blebs. You see blebs, there is no vessel on the surface of the lesion. Conversely, there is bulla here. You can see vessel on the surface of the lung, as you can see here. I think it's a very good indication for thoracoscopy procedure. And just to remind you that you can have the so-called type 1 pneumothorax, spontaneous pneumothorax from the former Van der Schuren classification. It seems there is not specific lesion in the pleural cavity. The type 2 and is when you have adhesion in the pleura. Which is important to know is that usually due to this adhesion between the chest wall and the lung, you can have an air leak at the basis of the adhesion. You have to make a careful examination of the basis of the adhesion. The type 3 with blebs, we saw, and a bulla at type 4. And then the thoracoscopy allow to perform a careful analysis of the pleural cavity, but also there are a few therapeutic indications, and mainly it's talc poudrage. As you know, in Marseille we use dedicated calibrated talc. It's a French talc, but it's the only one in this world calibrated asbestos-free. Yes, sir? No. a special session on pneumothorax
Oh.
if you want, but no, we can discuss this point in a bit. So far, there is no data. Pneumothorax session, very nice study with autofluorescence showing that the problem it's not the bleb or the bulla, the problem is the porosity of the visceral pleura in this case. And then resect bulla or blebs is questionable. We have in Marseille, since 6 months, a randomized phase 3 study comparing single talpoudrage in recurrent spontaneous pneumothorax versus surgical approach, pleurectomy, partial pleurectomy, bulla resection, just to see, but there is no study at the present time. Okay? Then, you have a patient with recurrent spontaneous pneumothorax. You can perform thoracoscopy. It's easy because you don't need artificial pneumothorax. You have a pneumothorax. You put 7 millimeter incision. You put your lens, you see what's happened, and at the end you can apply talc, and the results are very good. Very good. In Marseille we use a double balloon insufflator, but you have disposable insufflator now. From outside it's this. Which is important is to know that for poudrage, for pneumothorax, we use 1 gram of talc. It's an important point. And for recurrent malignant pleural effusion, we use 4 grams of talc.
Unfortunately, people here in Egypt will not be able to find this asbestos-free talc because I was doing maybe 8 years ago, my doctorate thesis was on pleurodesis, thoracoscopic pleurodesis, and I had Ahmed Halfawi bring me the talc from America, and it wasn't here, unfortunately, so that's a problem for us.
But the problem of American talc, we discussed talc after, but the problem of it was partly talc from China, which was very, very thin, and inducing a very huge inflammatory reaction and acute respiratory distress syndrome, which never happened with calibrated talc. But we discussed this point. The problem of sclerosol is the left sclerosol because it's under high pressure. The problem of this device from Novatec company, France, the left now. Because the problem is that there is first hyperpressure and you can get gas embolism. Second, the talc comes very cold at the end and you can get collapse due to the very low temperature of the talc. Now there is a disposal talpoudrage device, which is quite the same. It's a single balloon insufflator. You can do with this. It takes 30 seconds to apply talc. It gently spread into the pleural cavity, etc. From inside, you can get this kind of stuff. You see, very gently insufflated, etc. There is no hyperpressure. There is nothing, etc. It's efficient for sure. Excuse me? No, it is a problem. The problem is that it's not expensive and nobody is interested by this. No company is interested by talc because it's 10 euro. 10 euros a bottle. What application of? When you know now, at the present time, there are a lot of studies showing that the gold standard is talc in comparison to bleomycin, in comparison to tetracycline, in comparison to all of the study. If you check the Cochrane database concerning the symphysis, the gold standard is the talc.
I mean the technique for application also thoracoscopic or via the chest tube at the end of the procedure.
We discuss this point a little bit later? Okay, I have this for you. Okay. 2 comments. The first comment is, for pneumothorax, it's not useful. I assure you. a study we did in Marseille, experimental study, but on big animal. I can tell you that in normal pleura situation, pneumothorax is normal pleura situation, parietal pleura is free of disease, you know, talpoudouage is not relevant. There is no symphysis 30 days after. I show you, very nice picture for that. Second point is for recurrent malignant pleural effusion. You mean talc slurry in comparison to talpoudouage. In a study carried out by the American people, in the majority of recurrent malignant pleural effusion that come from the lung cancer situation at brain cancer woman, there is a superiority, statistical superiority of talpoudouage in comparison to talc slurry. I show you this too, okay? And then you have to get such spreading of talc into the pleural cavity, which is important, okay? In comparison to this, it's bad, very bad talpoudouage. It's very good talpoudouage, you know? I explain you a little bit later why. It was a basic indication of thoracoscopy. A more advanced step for using thoracoscopy is pulmonary biopsy. You can see here the procedure is very simple. You need absolutely second point of entry in this case, of course, using coagulating forceps. The method, it's easy. You grasp the lung, you pull the lung, and you apply a gentle coagulation, I mean around 20 to 40 watts, and you get a scar without bleeding, without air leak, etc. It's like this in live situation. It takes 10 seconds, okay? You have here a thoracoscopic lung biopsy. You have here transbronchial lung biopsy. You have here thoracoscopic lung biopsy. You have here surgical biopsy for sure. The size of surgical specimen from stapler, from wet digestion, it's superior to this. However, experimental study and clinical trial show that the message is, I would like to give you a simple message. There is no significant difference between a lung biopsy by thoracoscopy route, I mean using coagulating forceps, in comparison to samples from a surgical management using automatic stapler, okay? But if you need vessel in your specimen, forget thoracoscopy lung biopsy because it's not too deep enough. You understand? Otherwise, for superficial part of the lung, I mean interstitial lung disease, I mean carcinomatous situation, I mean infectious situation, etc., you can, it's very relevant. A guy from Belgium, Paul Van Takis, very nice guy, published this paper in 1999, or more than 70 patients undergoing this, and shown that there is no difference. And there is also experimental study shows there is no difference. You can perform lung biopsy by thoracoscopy route in few situations, okay? The last indication for me is MPM. Before doing thoracoscopy in MPM, you do not know if you have this kind of feature into the pleural cavity with fibrotic adhesion, or more advanced disease with this pus in the pleural cavity and also this adhesion, or a truly MPM, or finally, unfortunately, a fistula on the lung. And then there is a place for thoracoscopy maybe, but the problem is the time to perform thoracoscopy. In France now it's okay, the people refer to us, even surgeons, because the surgeons are very reluctant to put their hand in such situation, and sometimes he asks them, please take a look with thoracoscopy, and after, if you get problem, we go through for pleurectomy, decortication, etc., etc. But the problem is, if it's too late, it will be a very difficult procedure. But it's very interesting to perform thoracoscopy, to perform pleural debridement of the pleura, to create a single cavity in order to have a pleural cavity examination with a very efficient pleural cavity examination, and to put a chest tube drainage under visual control in a very appropriate position. As you can see, two examples for you. This first patient, it was a patient from North Africa with MPM, and we performed thoracoscopy with severe orthis adhesion. As you can see here, it's very inflammation of the posterior parietal pleura. The foot here, parietal pleura was here. We sampled this area. It was pleural tuberculosis in this case, and it was difficult to perform percutaneous biopsy due to the MPM in this case. The second patient, again MPM, with the second point of entry in this case, we severe the adhesion, and we had at the end of the procedure very good access of the pleural cavity, and we find the tumoral nodules in the pleural cavity. It was a pleural adenocarcinoma, I think. And I think it's important for us to manage such patient using thoracoscopy approach. I think the simple message and the most relevant message could be, if you need to put a chest tube in the pleural cavity in such situation, just take a look before. You know, my definition of thoracoscopy is just to put a chest tube under visual control. It's safer than to put a chest tube blindly, you know. And then it's my message, finally, before discussing with you. Comment, question, please? Yes, sir.
What about the cases of edema, the risk of the lung not to reinflate after thoracoscopy? There is a risk for the lung.
You cannot predict this. You cannot predict this. But in this case, the problem is not the reinflation of the lung, it's the sepsis, you know. And if you don't cure the pleural cavity, I mean, remove the chest tube, sever the adhesion, and it's taking a lot of time to perform thoracoscopy in patients with MPM, because you have to remove the pus, remove the fibrotic part, everything on the visceral pleura, on the part. It's easy, but it takes a long time. It's taking a long time. It's the reason why you have to sever off the adhesion in order to get a single, unique pleural cavity. Second step is to remove not the pus, the fibrotic part of the parietal pleura, the visceral pleura, etc. It is with optical biopsy force, like this. You can remove, you can peel the pleura, etc. At least you make a pleural lavage during the procedure. We fill up the pleural cavity with saline, etc. You remove all the stuff, etc. And you put chest tube in proper position. And the next day and the day after, we perform pleural lavage using saline, etc. And in majority of the cases, you can re-expand the lung, you know. But if you don't apply this, you get an hemi-refraction of the lung. You understand? And then after, it's a time for pleural decortication, which is not an easy procedure, you know, sometimes. It sounds great to start by medical approach, I mean thoracoscopy medical approach. If it's failure, you refer the patient to the surgeon. You know there is different. I'm going to perform this the procedure for this patient with 2 points of entry, one 7 millimeter, the other 5 millimeter incision. It's nothing in comparison to the scar after pleurectomy decortication. You understand? If you fail, it's not big. The message is, if you don't perform thoracoscopy, you are going to put a chest tube at that time. I don't know when, but in the story of this patient, you are going to put a chest tube. Just take a look before. You can see everything. You can make a lavage, appropriate lavage, etc. And you have time to think in 4 days, 5 days, 1 week, no more. It's not if after 1 week you cannot expand the lung, etc. It will be difficult. But sometimes even after removing the chest tube, we perform thoracentesis and lavage, and the lung will expand very slowly. And 1 month later, it's cured. It's re-expand, you understand? If there's a failure, it's not a big deal. You refer the patient to the surgeon. But you cure the sepsis, you avoid the retraction, the sequela, and potential restrictive syndrome later, etc. It makes sense, you know. It's a first step. First step is puncture, transcenthesis. It is MPM or not. It's loculated MPM or not. If it's loculated, depending of your facility, CT scan, ultrasound, etc. Yes, I can sever this adhesion by thoracoscopy route. You do. I can apply fibrinolytic drug inside. Just see. But if you need a tube, just put this tube under visual control. It's the same message, you know. The score is the same. It's the same point of entry. Yes, sir.
Local installation of antibiotics and lavage inside the pleural cavity in case of empyema.
There is plenty of studies showing that it's not relevant to put antibiotic into the pleural cavity. Because, you know, usually, you see, if you look at this, if you apply antibiotic here, the problem is that there is a fibrotic adhesion, etc. There is no absorption of antibiotic. But conversely, on the other side, there is an hypervascularization, you know, and then by systemic route, it's better.
Local effect. I'm talking about local effect.
Local effect?
Local effect, yes.
Of intrapleural antibiotic?
Yes.
There is no effect.
There is no effect.
It's not. No, there is studies showing that it's not effective.
Even in cases of acute cases of empyema, for some
No.
acute cases. Not these cases are chronic with fibrous bands, but I'm talking about acute cases. If we have empyema and patient had a intercostal tube, and we can install locally antibiotics.
Again, there is studies showing that it's not useful to put antibiotic into the pleural cavity. There is plenty of studies showing this point. Experimental study, clinical trial, etc. You cure your patient maybe, but maybe it's not the antibiotic, it's the lavage you did with saline, etc. It's enough. You understand? Sir?
I'm starting now a new project in my institution about this topic using thoracoscopy in management of empyema. We are trying to make it as one space.
It's a pity because it's not a pity. The problem there is the same study in Europe with between Italian guy, Greek guy, and guy from Switzerland. It's ESSB project. It's a pity because it's a rare disease. Maybe you can share your experience because
but
it's
we
good.
have many cases of
It's
empyema.
always better.
Okay. So we make it as one space and try to peel as much as we can the pleural beads. So, but I want to ask you about if there is a clear parameters of success or not.
What do you mean?
Clear parameters of success. Usually the X-ray would never.
There is no study concerning this stuff. The state of spirit is to say that when you have pus, when you have fibrotic part, etc., due to the lung expansion, etc., as your colleagues asked a couple of minutes before, it's better to peel everything. But the surgeon did the same thing. But he peeled also fibrotic part, but also the pleura, the cortication. But it's the same process, you know. If you can remove all the fibrotic part of the visceral pleura and on the parietal part, you open the lung stoma, you make the lung expand easily, etc., etc. It's a thing, but there is no study showing this.
And I want to warn you from something. You have to be very careful if you're going to cut up the adhesions. If there are vascular pedicles, it may be fatal.
Forceps.
Yeah, but usually
With the coagulation forceps,
yes.
maybe it's too much. The bleeding will be too much to.
Yeah, but usually in case of MPM, usually the adhesion are fibrotic adhesion. It's less vascular that it's happier, you know.
Mm-hmm.
Usually.
Until now, it never happened with us.
Yeah, I agree. For instance, here you see it is fibrotic, and then you can sever everything with the tip of your forceps very easily, etc. And you have here a vessel in this adhesion, and we coagulate with the coagulating force before to sever this. But you have to see, it's easy to see if there is a vessel inside in this case.
Another question, please.
But what is the true harm of your study?
No,
It's comparative study?
no, it is not a comparative.
It's a prospective study?
Yes.
Okay, using thoracoscopy and
Management.
debridement of the pleural cavity, etc., right?
Yes.
Okay.
Yes. Another question, please. You said that in suspected vascular pleural lesion, we use coagulating forceps. In this case, do we have to generally anesthetize the patient, or as well use local anesthesia?
This here, it's not painful.
Even if I use the coagulating forceps
It's not painful.
to the parietal pleura?
No, you are not on the parietal pleura. You are on the adhesion.
In the space between.
You are in the space in between.
But
It's
if
not-
I by mistake touch the parietal
No,
pleura and the
no,
patient?
no. In this case, no. You know, in case of empyema, you have a very sickness of the.
No, I'm not talking about empyema.
No, empyema.
Generally, if I'm biopsying the parietal pleura with suspected vascular lesion,
If you sever the vascular lesion, you can do under local anesthesia. But the problem is to touch the parietal pleura, which is very painful.
yes.
It's a reason why I don't advise to apply talpoudrage in patients with spontaneous pneumothorax under local anesthesia. Please. At least in France, I can tell you, because it's a real problem. The sensitivity is very low, in particular, young boy. You cannot. It's a challenge, but it's terrible pain. You have to use morphine, etc. But coagulation, in this case, you don't touch the parietal pleura. You can coagulate an adhesion, vascular adhesion, but it's very rare not to have such adhesion. You know, if your indication is to perform a symphysis, you don't have to severe adhesion. Okay? If your indication is to improve the examination of the pleural cavity, of course you have to severe the adhesion. Absolutely. You understand? Yeah. But it's a very rare situation, actually, because it's if you have a strong suspicion of malignant pleural effusion, if you have two nodules on the lymphatic part, and if you have an adhesion on the upper part, you don't have to see what's happened, because you have the diagnosis.
We'll search for
you understand? It's practical situation. I'm sorry, but it is. You have to make your procedure. We are not surgeons. We have to make our procedure safe and easy, because 15 years ago I used taper inside, 3-point of edge, pericardial window, etc. Sympatolize, which is very easy to do. Everybody knows to do that, but it's not our job.
Yeah.
My purpose today is to show you all this panel we can do, but our job is to do this, and this. Of course, with my mentor, Professor Boutin, we did more than 100 pericardial window, refer from the cardiac surgeon. You know, we left. It's not our job. We can do. It's easy to do. You can be ultrasound and pupil puncture too, but it's not a job. There is cardiology, there is thoracic surgeon, etc. for that. You know, to apply stapler, to make a wedge resection during the thoracoscopy, even medical thoracoscopy, you add another point of entry, triangulation. It's easy to do. Everybody in CISO can do. I can show you in the afternoon after 5 or 4 procedure, you can do this, but it's not our job. We are physicians.
Yeah, we were talking about this earlier today, me and you.
Yes, but absolutely, I agree. I totally agree with this. Yeah. We are a discussion, because it's our job. You know, the aim of such course, a workshop, is to define what is possible or not. Pleurisy, it's our job. Pneumothorax is our job. Pleurisy, it's not a problem. Pneumothorax, it's a little bit more controversial with the surgeon, but I hope to finish our study in Marseille very, very quickly, because we did also, during the ongoing phase 3 study, we are doing also, but surgeon ask us, because the surgeon are sure in Marseille, they are a very nice guy. There is no difference. It's a non-inferiority study. They know the results, not difference. But we are doing also an economic approach. It's more cost-effective, managed by thoracoscopy route, I can tell you. And with administration, it's a very good argument to develop such technique. Okay, surgeon can do, we can do, but you know this cost, it's all the point.
I
You
totally
know,
agree with you.
it's very important, such approach. But the reason, we know, I know that there is no difference. I can tell you, I performed thoracoscopy for 22 years. I can tell you there is no difference between the surgical approach. Sometimes we have failure, but it's rare. But surgeon too, you know. Sir? What do you mean? Do you mean I want to start thoracoscopy program? Do I need a surgical department very close for me? Okay. I don't know. I changed. I moved from one hospital to another. I performed thoracoscopy for 16 years without surgical department in the hospital. Okay? I refer in 18 years, I refer 2 patients to the surgeon, but you know, nothing happened at the beginning. It's happened after. When you perform some pathologies, you get bleeding. When you want to dissect something, and you want to see the mediastinum to take okay. I refer 2 patients, but the surgeon just survey him. No operation after, you know. Everything can happen. But I have a question for you. You are pulmonologist, you perform maybe bronchoscopy. Do you ask if TBB is surgical department is useful when you perform TBB? No? I can tell you that hemoptysis, it's more frequent than problem, actually. And you don't answer this question. You perform bronchoscopy, maybe laser resection, I don't know. You don't ask, do I need thoracic surgical department? No. Why? No. Everybody in this room knows to put a chest tube in the pleural cavity. Please. If you can insert a chest tube in the pleural cavity, you can insert a telescope. It's the same. Just replace the tube by a telescope, and you can take a look. Yes, if you see something wrong, you take a biopsy. Just by the way, but it's the same procedure. No, I'm not joking. Okay?
You make it sound very, very, very simple.
But it is.
But the safety, you know, because maybe not everybody here also knows how to put a chest tube in. The safety right from the beginning, from entering the space and the intercostal nerves and blood vessels and.
Absolutely.
Yeah,
but you know, there are few basic requirements to start. We discuss point of entry, facing the patient, the special area of the parietal pleura, avoid intercostal space if you can, not blunt period during your procedure. Nothing can happen.
And then because you also work always, you induce pneumothorax, but you know, can you imagine somebody who enters into, he just has a CT, and then he supposes without even ultrasound or pneumothorax that there are no adhesions, and he goes in with a trocar, a metal trocar, and he punctures the lung. You know, it's, I mean, of course, with your expertise, it's very simple, but people have to be careful. I mean.
Sure, sure. You have to be careful for any procedure, you know, even when you perform thoracentesis.
Exactly.
If you look at the literature with the complication of thoracentesis, percutaneous blood, it's huge. After reading, after making the search, I can tell you are very reluctant to perform. I'm more comfortable when I perform thoracoscopy than percutaneous blood biopsy. I did a lot of percutaneous blood biopsy, and I teach this procedure to my fellow because you have to know. It's the same that I don't know. A student asks you, "May I put a central vein line?" Yes. How many peripheral vein line you did? 0. Please, you put here, and after I show you central line. Sir, I would like to perform thoracoscopy. Good. How many chest tube you are insert? How many percutaneous biopsy you did? 0. Okay. We do insertion of the chest tube, we do percutaneous, and then we move to thoracoscopy.
Exactly.
It's a basis of our job, I think.
You know, the one point you were talking about is that because you use the pneumothorax needle first, then you don't have to use ultrasound, even if you have a CT with effusion, because you can never, especially if the effusion has been for a long time, you can never be sure that there are no adhesions, except if you do, for example, the technique of the pneumothorax needle, then the next day you observe, or by ultrasound, either or. My question is, because this is a good alternative, because the ultrasound is not very available or quick in most of our sections to do it.
I don't do ultrasound.
Yeah, I
I
mean-
didn't need. I asked,
Yeah.
you know, my fellow asked me, sir, okay, then you told us where you want to perform the point of entry. And after we perform ultrasonography and we choose ultrasound guide point of entry, and we see. There is no difference.
Yeah.
Of course. But even for suspicion with pneumothorax, for instance, when I perform thoracoscopy, my first step is to insert needle,
Okay. So my question
just
is,
to feel what's happened.
if it's massive effusion, the needle that has a one-way valve, the fluid doesn't jump out, the needle you use for the pneumothorax. If it's massive effusion and you want to induce pneumothorax.
In this case, it's a good question because in this case, when you have a massive pneumothorax, No.
Effusion.
Effusion. In case of a massive effusion, it's a good question. It's
No,
a
if you
good-
have adhesions.
It's
because
a good. In this case, we have massive effusion with, of course, with shortening of breath, etc., etc. When you put the needle, there is a positive pressure into the pleural cavity, and the fluid going inside. But
you wait.
you don't aspirate.
Yeah, you just
It's
wait
just
and-
coming like the, it's important, you know, because if you aspirate in this case, you make reinflation, very fast reinflation, and you get pulmonary edema in this case.
Yeah.
And my advice is to postpone the procedure because you leave the lung re-expands a little bit, and that because of the surfactant, etc., it's better, and I think it makes the procedure easier, and the patient is going to not cough, etc. And then we can tap the fluid 1 or 2 times before the procedure, just to make the expansion of the lung, and then it makes the procedure. But
Because
the second time, you can open at the end when you remove the fluid. You can open the needle and you have artificial pneumothorax.
Because you know the problem here, Dr. Philippe, and maybe I'll be talking about the other centers, because we started, as you know, in Cairo here in '98, and I was one of the first people in Cairo to work with this. So we have this false perception that if the CT shows massive effusion, okay, it's safe, let's go in with thoracoscopy. So this is a problem.
No. You have you don't have to aspirate in this case because you know you have.
Just aspirate 1 liter.
How do you?
No aspiration. It comes spontaneously.
You can find the problem. تلاقي بعد الافيوجن ده دخلتي في مشكله ادهيجنز رهيبه وما انتيش عارفه، فهي اما الترا ساوند يا اما طريقته بتاعت النيدل.
Pressure positive, and of course it's like this. And if you put a needle here, from atmospheric pressure here, for sure, the fluid is going like this. And you don't have to aspirate. Makes spontaneously the fluid is going to be out of the cavity till the balance between atmospheric pressure and intrapleural pressure. You understand? And then it's the same for compressive pneumothorax. If you have compressive pneumothorax, you have a balance of the mediastinum like this, which means that you have a very high intrapleural pressure. The first step is patient asphyxiation, etc. You put the needle like this and you deflate.
No, so what we do here, this means that this is not actually correct what we're doing. We enter with the thoracoport, and then you find fluid.
No, because
then it's, it's terrible.
You make a fast depression
Yeah.
in this, and you can get pulmonary edema. You make the patient cough for long.
And then you can never be sure what you have inside from thick adhesion. You can never tell 100%. Yeah.
You can tap the pleural before, gently. You see what's up. It's spontaneous.
Yeah.
As you remove
Yeah, I know. I mean,
It's the same.
no, I mean, if we didn't do this, if we just directly with the thoracoport, it's a big problem.
Because you have a collapse like here,
Yeah.
and when you raise another, you suddenly
Pulmonary edema, and then maybe you find yourself in a situation where you have a trapped lung and you didn't know even if there's, yeah.
Provide that with adhesion, this is protection. Yes, the fluids will not touch immediately.
Adhesions?
Yes.
What if, for example, you have
I mean
you
it.
have a lot of adhesions and you have a lot of fluid, and then you enter one of the you enter in the adhesions, you empty the fluid with the thoracoport, okay, and then you find yourself in the middle of a trapped lung. What did you do? How did you help the patient? You know, and maybe you cannot solve the situation.
We used to open, and then after that suction only for 1 liter till the view is.
No, the aim of this workshop
visible
now,
for us.
the aim of this workshop now is even for me to understand what we should do properly.
Yeah.
So I think Dr. Philippe will agree with me. If you have, even on the CT, if you have a large amount of fluid, you should either use his technique, put a small pneumothorax needle and induce and remove fluid,
Even in the massive.
even in massive effusion, remove, because he doesn't want you, if you go immediately with the thoracoscope, I've done it.
Yeah.
You find fluid splashing in the ceiling, and then the patient coughing, especially if it's local anesthesia, and maybe you'll have pulmonary edema.
Yeah,
It doesn't have to happen all the time, but believe me, it will happen to some degree. So if you want it to be a cool
I mean,
and
there
slow
is
process,
adhesion, and this diffusion.
Even if
This
there's
is a
no-
protection
even if there's
for
no
us
adhe- no, it's
against
not.
the gusher.
no, it's no protection. Of course not. You don't want to work with adhesions. Unless you know that you're going to work with adhesions, it's up to you to cut them. But if you want to do a simple medical thoracoscopy, you would not prefer that there are adhesions in the way blocking your way. So what you do is that even if you have a CT, and correct me if I'm wrong, please, Dr. Philippe, even if you have a CT and with a lot of fluid, either you put the needle in and slowly drain the fluid and wait for pneumothorax, and the next day repeat your X-ray before you go in smoothly, or you can do ultrasound, and they can tell you that there are no adhesions. And then also be careful, because if you go immediately with the thoracoscope, you can do re-expansion pulmonary edema if all the fluid comes out immediately. So let's all correct what we're doing, even if we were doing it wrongly in the beginning, okay?
Okay, just I want to come to the management of pleurisy, if you want. Just to, the first step is thoracentesis. No doubt on this case, but I just would like to come back to a few, to make a few comments. As you know, malignant pleural effusion, we have to know the primary tumor sites, which are the lung cancer and breast cancer in majority. The others are less frequent. And just to show you this study, old study, because the new study shows the same results, it's that patients with malignant pleural effusion are usually underdiagnosed, because if you compare the patient with malignant pleural effusion and the patient with malignant pleural effusion at autopsy, checked by autopsy, as you can see here, it's much, much more important, more frequent, and then there is an underestimation of the malignant pleural effusion, which is a very frequent situation, even with teeny amount of fluid, very frequent situation. But it was our discussion a little bit, a couple of minutes before. Before doing thoracoscopy, in case of, for instance, you have a patient, we know that this patient has lung cancer. This patient has pleural effusion, you tap the pleura, it is positive cytology for cancer cell, okay? But before doing thoracoscopy, you do not know what's happened inside. And taking into account what I show you at the, for microscopic approach of the pleura, you are familiar now with this pathology, you do not know, in this case, of positive pleural cytology, if there is tumor emboly to the visceral pleural surface, as we can see, for instance, in case of secondary seeding to the parietal pleura, or if it is, for instance, in breast cancer situation or chest wall neoplasm, direct tumor invasion, of if there is hematogenous spread to parietal pleura or lymphatic involvement. And then it's impossible to predict the involvement of the visceral pleura and parietal pleura. and you see, M1. But when I start the course 20 years ago, with my mentor, Professor Boutin, we tell that it cannot be T4. It's impossible because we know what's happening inside. Before doing thoracoscopy, positive